Hello guys. So now that we are done with the upper limb and lower limb, now it is time that we move on to pathogenesis or pathologies of these musculocutaneous system. Okay. So starting with, we'll go on with the orthopedics. So orthopedics, the main thing is bones, right? So in bones, there are two types of cells. That is, one is osteoblast and then is osteoclast. So osteoblast is the builder, okay? Bob the builder, right? He builds stuff. So B for builder and C for cutter. So this cuts or resorbs the bone, okay? Remember in that way and it will be easier for you, okay? So osteoblasts are the builders, whereas osteoclasts are the cutters. So, to know the activity of osteoblast or osteoclast, there are two types of tests. So, if there is increased activity of the osteoblast, that is the building, so it will be the ALP that will be increased in the blood. If it is the osteoclast activity that you wanna see, then it will be the TRAP that levels will be raised in the blood. Okay, so this is very important. Then coming to fractures, there are different types of fractures which happens in the bone. So we are starting now with the pathologies of bone. So starting with fractures. Okay, so there are different types of fractures in the bone. So you can remember main four as the transverse fracture, the oblique fracture, the bending fracture, and the spiral fracture. Okay. So what happens is when there is tension from two sides of the bone, then the transverse fracture happens. So transverse fracture looks just like this. Okay. So transversely through the bone. Then oblique fracture is the opposite of the tension, right? So it is gonna be compression of the bone. Okay, so when we compress the bone, it is gonna be oblique fracture. Then when we bend the bone, it is gonna be the butterfly fracture. Okay, then twisting the bone will cause the spiral fracture. Okay, this is the spiral fracture. If we twist a bone and the fracture happens, then it is going to be spiral fracture. Okay, so these are the types of fracture we can see. Then coming on post fracture, the healing happens, right? So after a fracture, if you go to a doctor or any an RT practitioner, so fracture has to heal. The bone starts healing. This healing happens in two ways. One is primary healing, whereas the second one is secondary healing. Okay, so primary healing happens directly by dense bone formation, whereas secondary healing happens through callus formation. What is this callus? Callus is hematoma formation, then the cartilage bone formation, then the proper bone, and then after formation of the bone, remodeling through the osteoclasts and osteoblasts happen. Okay, so this is callus. Callus formation takes place first by hematoma formation, then the cartilage, then the bone formation will happen, then the remodeling of the bone will happen. The stable way of healing of a fracture is through primary. Okay, the secondary healing is not quite stable as compared to primary. Okay, that is the thing that you have to remember with respect to types of fracture and the way the fracture heals. Then suppose a patient comes to you with a fracture, what you guys are supposed to do? Okay, so now let us go on with, as you being a doctor, how the management will be there with respect to fractures. There are two types of fracture with respect to how the patient presents with. Okay, these are the types that I discussed above are the types of fracture that the bone can see. Okay, but when we as a clinician go and examine, it is gonna be two types of fractures that the patient might present with. That is, one is open fracture and another one is closed fracture. Now, let us discuss about open fracture. Open fracture means that the skin has been seen opened. Okay. Whereas the closed fracture, the skin is intact where the bone is cracked. Okay. So these are the two types of fracture that we can see. In open fracture, there is a classification called Gustilo-Anderson classification where the three stages of classification has been done. Okay, there are three types of classification where in which the first type is less than 1 centimeter of the skin opening. The second stage is more less than 10 centimeter of skin opening, whereas the third stage is more than 10 centimeter of skin opening. Okay, so I told you, right, open fracture is skin will be opened, but and the bone also will be fractured. Okay, so we can divide them into these three types of classification. That is, 1 will be less than 1 centimeter, 2 less than 10 centimeter, whereas 3 is more than 10 centimeter. Then coming to closed fractures, there are intra-articular and extra-articular classification, okay, or the fractures. So what is intra-articular fracture? So suppose this is a bone and there is another bone. If the fracture happens within the joint, this is a joint where the synovial membrane is there, synovial capsule is there. So if a fracture happens somewhere here, here, okay, so within the joint, right, this is the joint. So if a fracture happens inside the joint, then it is gonna be intra-articular fracture. Whereas if the fracture happens above or not in the joint, in the joint is intra-articular, whereas not in the joint is extra-articular. Okay, extra articular. So these are the two types of fractures that we can see in the closed fracture. Open fracture, just when someone tells or someone presents with open fracture, just go for Gustilo-Anderson classification, and there are three types. So that is how you decide how to manage that patient. Okay, then when it comes to closed fractures, so now the skin is intact and you wanna decide what type of fracture it is. So you'll tell them to go take a x-ray, whether it is open fracture or closed fracture. Both of them you will tell take an x-ray. But when it comes to closed fracture, it is going to be intra-articular or extra-articular classification. So because it is going to be different in the way we manage both the fractures. Okay, so in closed fracture, suppose it is an intra-articular fracture, then it is going to be open reduction and internal fixation. No matter who it is going to be open reduction and internal fixation. Okay, suppose it is extra-articular fracture, then it is going to be conservative type of management. Okay, so intra-articular, it is going to be open reduction and internal fixation, meaning we are going to open the joint, we'll fix with the rods, plates and all these things. I'll tell you what we'll use for what. So so it is going to be, we'll open the fracture, it is going to be a surgical management, and we'll internally fixate it if suppose it is inside the joint, because joint is an unstable a thing, right? So we cannot stabilize just like extra-articular fracture. Extra-articular fracture, conservatively we can manage by putting a slab or any POP as such things. Okay, but intra-articularly it won't be stable, right? Because we will be keep on moving. That is why we are supposed to go and do the open reduction and internal fixation. Okay, that doubt is cleared. So now that we have decided that is gonna be internal fixation that we are gonna do, and in extra-articular fracture also, suppose if the conservative management is not proper, then we'll have to go to internal fixation. So how we are gonna do and what are the things that we are gonna use? Okay, suppose if it is an upper limb, then we will be going with screws and plates. Okay, screws and plates is what we are gonna choose. Okay, suppose it is lower limb, then it is gonna be rods and nails that we use. Okay, so that's it. This is how we are gonna manage a fracture. Open. So a patient comes with you with a pain of bone, and now you'll tell them to take an X-ray. Then you'll divide them into open fracture and closed fracture based on skin, whether the skin is intact or not. Then you'll go on with, suppose it is open fracture, it is going to be Gustilo-Anderson classification, and based on the Gustilo-Anderson system, you'll go and manage it, wound debridement and all these things, and then the fixation of the fracture that you will do. Suppose it is closed fracture, you'll decide whether it is intra-articular or extra-articular. Then you will choose, if it is intra-articular, then you will go for open reduction and internal fixation. Suppose it is, if it is upper limb, screws and nails. Suppose it is lower limb, then it is gonna be rods and nails. Okay, that's it. So extra-articular, it is conservative, that is slabs and POPs that we are gonna use. Okay, this is how you manage a fracture. Then there is one more classification in joints. Okay, so like for example, I told you, right, intra-articular fracture a patient presents to you. We will also be seeing a Salter-Harris classification. Okay, so according to Salter-Harris classification, in the name itself, we'll be having the mnemonic. Okay, Salter-Harris classification, where suppose a bone is there, and above the epiphysis there is a crack, then it is gonna be straight, right? So straight across the epiphysis it is there, then it is gonna be yes, straight. Okay, type 1 of Salter-Harris classification. Then type 2 is above the epiphysis. If the fracture is there, this is the intra-articular. Okay, so suppose if the fracture is above the epiphysis, then it is gonna be type 2. Then if it is gonna be below, low, okay, lower below, okay, so it is gonna be type 3 classification. If it is through the epiphysis, then it is gonna be type 4. Whereas if it is rammed, okay, so epiphysis is rammed by the below bone or the above bone, then it is gonna be type 5 classification. Okay, so these are the two classifications that I want you to remember in fracture. Gustilo-Anderson classification for open fractures, then Salter-Harris classification for intra-articular fractures. Okay, that's it. So this is the basics of orthopedics that I want you guys to know before we move into the specifics of upper limb and lower limb. So now let us move on to the upper limb. Fractures, disorders, all the things we'll see here itself. Okay, so now coming to humerus, if there is a fracture in the shaft of the humerus, then we'll be getting to see the radial nerve damage, as we discussed in the upper limb chapter. So radial nerve damage might happen in axilla, shaft, or in the forearm, right? So if there is a fracture in shaft of the humerus, so it is the most common fracture if the shaft of the humerus is affected. Okay, so this is the most common presentation. Okay, so radial nerve injury, it is gonna present with claw hand, right? We discussed in the upper limb chapter. Then what is the type of classification that the humerus fracture or the neck of the neck or head of the humerus is having is Neer's classification. They'll not ask what stage the classification or the fracture is in. They'll just ask you an image of a shoulder fracture, and then they'll ask you what type of classification that we use to classify these type of fractures. Okay, so that is the question they have been asking all these years. They are not very keen in asking what type of or what stage of Neer's classification that this fracture is there in. Okay, because this is not a final year exam, this is going to be a competitive exam. That is all and everything you need to know. You are not an orthopedician, you are just trying to give a postgraduate entrance exam, right? So this is what they have been focused on. Then moving on to shoulder dislocation, this they are very interested in with respect to the shoulder dislocation signs that the shoulder dislocation types produce, and the type of management that you guys need to know. Okay, so there are two types of shoulder dislocation. One is anterior dislocation, the other one is posterior dislocation. Anterior dislocation is gonna present with two signs, that is Hill-Sachs lesion and the Burkhart's lesion. Okay, then posterior dislocation, when you take an x-ray, it is gonna be light bulb sign that it's gonna present with. Okay, Hill-Sachs lesion and Burkhardt lesion in anterior dislocation, whereas posterior dislocation, it is gonna be light bulb sign. Okay, then coming to management of shoulder dislocation, it is gonna be there are many types of management that we can do with respect to shoulder joint. Many orthopedicians, they have their own method in solving it. The most common method that we use is Kocher's method, which is gonna be team. Remember it as team. Okay, traction. What we are going to do is, suppose a patient presents to you with shoulder dislocation. So what we're going to see is, most of the time they'll present with the flat shoulder, right? So what we are going to do is lie them down, then you do traction, external rotation, adduction and medial rotation. Okay, so this is team. What you're going to do, traction, you'll pull the arm, then you'll make the external rotation of the arm, then you'll adduct the arm towards the body, then you'll do the medial rotation. So this is how the shoulder head, the humerus head will go back into the glenoid cavity. Okay, then so as I told you, there is Holstein-Lewis fracture, which will be in the radial groove. Suppose let us say this is the humerus. Okay, so there is a head of the humerus, there is a groove here, which is called the radial groove, where the radial nerve will pass through. So if a fracture happens here, then it is the Holstein-Lewis no, this is the Holstein-Lewis thing. But if it is gonna, if the fracture happens just 1/3 of the humerus, then it is gonna be Holstein-Lewis fracture. Okay, so please remember this name, Holstein-Lewis fracture. So where the radial nerve will be getting injured in the lower 1/3 of the humerus. Okay, then coming on to elbow. So there is going to be dislocation of the elbow, that you should be mainly focused on. And then there is condylar fractures. Dislocation of the elbow and the condylar fracture is what you are supposed to remember. Dislocation of the elbow, so this is called nursemaid's elbow, where pulling of babies, a baby or a child below 5-year-old is most common. So nursemaids, they what they do is try to hold the hand of the baby and try to turn, right? So during this, the annular ligament might slip out from the elbow or the ulna. So that is where you get this dislocation. So how you manage this is flex and supinate the elbow. Okay, so hold the baby's arm, or hold the baby's hand, then what you do is flex and supinate. Try to flex and supinate the elbow, and it will go back to the a specific position that it has to hold. I mean, the annular ligament will try to take back the elbow into the proper position. Then the important fracture that you want to discuss with respect to elbow are the lateral condyle fracture and the supracondylar fracture. Lateral condylar fracture, this is a type 4 Harris type of classification. What was type 4 type of Harris classification? Salter-Harris classification. What was the type 4? It is gonna be through, right? So suppose if this is the condyle, so if it is through, then it is gonna be Salter-Harris type 4 classification, right? So this is how the thing is gonna present, the lateral condylar fracture. So when the lateral condylar fracture happens, it is gonna present with a complication where the medial side, see, in the medial side, the ulna will be traveling, right? So when the lateral side of the condyle is gonna be fractured, suppose if there is no proper healing, then what happens is, this condyle starts growing outwards and away from the joint. Okay, so what happens is this ulnar nerve might get injured because there is bending of this bone. Okay, so that is when the ulna might get fractured. What we'll be thinking is lateral side, it is gonna be median nerve that would be damaged. So that is why the name tardy ulnar. Okay, so it is not the median nerve that is gonna get damaged, but rather than it is gonna be ulnar nerve that is gonna get damaged. So this is lateral condylar fracture, which is going to be type 4 Salter Harris classification, and then there is going to be tardy ulnar nerve palsy, which is going to be in lateral condylar fracture. Then moving on to supracondylar fracture, it is going to be type 1, type 2 and type 3 type of classification. Okay, so supracondylar fracture has three types of classification. It is going to be type 1, type 2 and type 3. Type 1 will present with sail sign, type 2 with posterior cortex is intact, whereas type 3 the fish tail pattern can be seen. So these are the three things that you need to remember. Please note this down in your sticky note. Okay, supracondylar fracture, there are three types. The first type is the sail sign we are going to see in the fracture x-ray. Then the second one, the posterior cortex will be intact. The third one will be the fish tail sign that we'll be seeing. Okay, then if it complicates, then we are gonna see gun stock deformity. This you would have heard since your first year, right? So it is gonna give a sign called gun stock deformity sign if there is a malunion of this. So this looks like a gun, right? So it is how the hand would look like. Okay, so if there is a malunion practice due to some naughty approach for healing of the fracture, so then it is going to be the gun stock deformity, which will be the malunion of supracondylar fracture. Then how will you manage? So you will be managing through Dunlop traction. Okay, so there is a image based question based what Dunlop traction would look like. Please go through Google and please type Dunlop traction and you would get to see an image. So please be aware of that image, Dunlop traction. Okay, so this is a much more and much what the elbow fracture would have to provide for you. Then there are two other pathologies, that is tennis elbow and the golf elbow. So tennis elbow will be the lateral side, lateral condyle, whereas golf elbow will be the medial condyle. Okay, so remember these two things. Tennis elbow will be the lateral side, whereas golf elbow will be the medial condyle that will be affected. Okay, so that is everything that you need to know with regards to elbow. Okay, so we are done with humerus. Humerus was shoulder dislocation and the signs that we saw, and how to manage the shoulder dislocation we saw. Then coming to elbow, it was dislocation, again dislocation here also, and then two types of fractures that we saw: lateral condyle, supracondyle. Lateral condyle, just think of tardy ulnar nerve palsy, whereas supracondylar fracture, think of three signs, that is three types of classification that the supracondylar fracture has. Okay, then the tennis elbow will be lateral, then the golf elbow will be medial condyle. Then coming to forearm, it is gonna be two types of fracture that is very important. One is Montague fracture, then the other one is Galeazzi fracture. What is Montague fracture? It is gonna be ulnar fracture with radial bone dislocation. So it is gonna be, so suppose this is radius and this is ulna. So we are talking about MG. Remember MG car, okay? So M starting above, it is going to be ulnar nerve fracture, ulnar bone fracture, whereas radial nerve dislocation at the distal end. Okay, then so it is going to be ulnar fracture and radial bone dislocation. Whereas in the Galeazzi fracture, it is going to be a radial fracture and distal, it is going to be radial fracture and distal radio-ulnar joint dislocation. Okay. So two opposite things that we are gonna see in the presentation of Montague fracture and Galeazzi fracture. If you have a doubt, just remember the name MG, okay, in that order from proximal to distal. MG, which is Montague fracture will be ulnar joint fracture, Montague, then Galeazzi fracture will be radial fracture, okay. So in that way, if you remember, it is gonna be easy for you. Why these fractures are important is because in Montague fracture we'll get to see PIN damage. PIN, which is posterior interosseous nerve, is a branch of radial nerve which will provide the extension for extension of the wrist. Okay, when this is affected, then there is gonna be claw hand. Okay, so that is why this Montague fracture is very important, where the radial nerve might get injured. The rather than radial nerve, it is going to be the branch of radial nerve, that is PIN, which is getting injured. Then Galeazzi fracture is gonna present to you with a piano key. When we see a fracture that is gonna be Galeazzi fracture, it is gonna just look like a piano key where you can just press and you can it will just go and come back. A piano key also is gonna be like that only, right? So it is gonna go and go down and come back in that way. It's like a spring. Okay, so that is how the Galeazzi fracture is gonna present to you with. Then coming to wrist, so now we are done with the shoulder joint, elbow joint, and then the forearm was done. Coming to wrist, wrist joint, so it is gonna be Colles fracture, Smith's fracture, Schaffer's and Barton's fracture that you're gonna worry about. Okay, so Colles fracture and all these things, all these fractures, so this has been since your first year also, this is the present with. Okay, so the Colles fracture is gonna present as dinner fork, whereas Smith's fracture is garden spade, then the Schaffer's fracture and the Barton's fracture. So Colles and Smith's fracture, you see, so Colles fracture is gonna present to you just like a dinner fork. Okay, then the Smith's fracture will present to you just like a garden spade. Okay, so this is how the fracture is gonna present with. Just know how these fractures will present with, and you will be able to solve the questions. So it is gonna be the X-ray that they are gonna ask you. Then so this is gonna be foosh. Okay, fall on outstretched hand is what is the etiology for this fracture. Okay, then there is Schaffer's fracture, which is gonna be on the lateral side of the radius. Suppose this is the radius, so if the fracture happens here, then it is gonna be the Schaffer's fracture. Suppose I'm seeing a radius, this is the radius. Okay, so radial head, so if the fracture happens on the ventral side, okay, so this is from the above I am seeing the radius. If I am seeing from the lateral side, this is the lateral view of the radius, lateral view. So this is the PA view. Okay, so if the ventral fracture happens, then it is going to be Barton's fracture. If the dorsal side happens, that is also Barton fracture, which is going to be the dorsal Barton fracture. This is going to be the ventral Barton fracture. So these are the types of fracture which are important with respect to wrist joint. Okay, then moving on further with hand, so it is going to be the first metacarpal and the fifth metacarpal that you should be focusing on. Okay, there are two types of fracture that occurs in first metacarpal. That is, suppose this is the metacarpal. If both sides of the metacarpal base is affected, then it is gonna be Rolando fracture. How you are gonna remember Rolando fracture? It is gonna be CR7, right? CR. Okay, two names, two sides. Okay, so if two sides it is affecting, then it is gonna be Rolando's fracture. Whereas if it is affected only on the one side, it is gonna be Bennett's fracture. Okay, so if two sides are there, then it is gonna be a Rolando's fracture. Whereas only on the one side, then it is gonna be Bennett's fracture. Then fifth metacarpal bone in boxers. When a boxer hits someone's jaw or a wall or something like that, or when he is practicing with during sparring session and all, so this is the most common fracture that you will be seeing. in boxers, it is going to be fifth metacarpal that is going to be affected. Then mallet's fracture is where the extensor digitorum, okay, so suppose this is a finger or the distal phalanx, and suppose there is a this is the tendon of extra digitorum, okay, digitorum communis. So if there is a tendon rupture, then it is going to be the mallet fracture that will be seeing, okay. So the mallet presentation that will be seeing. Then coming to tenosynovitis, this is the most important question in upper limb, okay. So if they don't ask any of the question, this is the question that they are definitely gonna ask. Where so suppose if you you have seen this anatomical snuff box, right? So when you see the anatomical snuff box, the two main tendons that you're gonna see is abductor pollicis longus and extensor pollicis brevis, okay. So these are the two tendons that you will be seeing, okay. So suppose this is the hand, okay, so make a fist of it. So you have made a fist. So this tendon, there are two tendons here, okay. So that tendon, if it gets if there is inflammation of this tendon, then it is going to be tenosynovitis, okay. So the two tendon names you are supposed to know, that is abductor pollicis longus, extensor pollicis brevis, okay. Longus is the longer muscle, brevis is the shorter muscle, okay. There is one longer and one shorter muscle, okay. So this is all you need to know with respect to upper limb, okay. So I have explained to you shoulders, shoulder, humerus, elbow, forearm, then the wrist, then the hand, okay. So everything about the upper limb that you need to know and that are very important, I have explained to you, okay. Now moving on with respect to lower limb. So lower limb fractures. So what you need to know, the only thing that you need to remember with respect to lower limb, pelvis fracture, we'll be starting with pelvis, okay, then we'll move on to femur, then the knee, then the foot, okay. So with respect to pathologies of lower limb, starting with pelvis, only thing that you need to know is when you get a patient with a pelvis fracture, you should do bedsheet binding, okay. So to stabilize the joint, all you need to first, suppose for example you see RTA or a road traffic accident, and you are suspecting a pelvis fracture, what you are supposed to do as a first aid is bind the bedsheet around the pelvis and you will stabilize the pelvis fracture, okay. So that is the thing that you need to know. So we are done with pelvis fracture. Moving down with respect to femur, there are two types of dislocations that you can see in humerus also. In the shoulder joint also, we saw two types of dislocation. One was anterior, one was posterior. Anterior, I told you, right, two signs are there. Then posteriorly we will get to see the light bulb sign with respect to x-ray, okay. So in the same way, in the femur also, there are two types of dislocation which can be seen. One is anterior, the other one is posterior, okay. So posterior dislocation is gonna be the dashboard fracture, you know that, right? When there is a car and this is the dashboard. So suppose if you are sitting like this, consider this the leg, and this is the thigh. Suppose this is the thigh, then this is the femur, okay. So inside the leg there is a femur, okay. So when there is a force that hits dashboard, that hits the dashboard, so the main thing that you're gonna see is this femur head will get dislocated to the posterior. So this is the posterior, right? So it is gonna go posterior. Anterior dislocation will happen when there is a force from the back side, okay. So this is going to be anterior dislocation. Posterior dislocation when the force is from the anterior side. Anterior dislocation when the force is from the posterior side, okay. So how are these going to present is what they are going to ask, okay. Posterior dislocation is going to present with flexion and internal rotation, okay. So flexion, So the thigh will be flexed and internally rotated in the posterior fracture. So just you yourself think of how it is gonna present. Okay, so there is a force from the front, so the thigh is gonna go back and gets flexed and internally rotate. Okay, now the anterior fracture is gonna present with flexion and external rotation. Okay, so suppose there is a fracture from, there is a force that is coming from the back. Okay, someone pushes you or some accident happens, the fracture is gonna go flex the hip and then externally rotate the hip. Okay, so this is how the dislocation of anterior and posterior dislocation is gonna present to you with. Then with respect to femur, there is one more thing that is important, that is neck of the femur fracture. Okay, so in the neck of the femur fracture, there is going to be extra capsular fracture, then the other one is intracapsular fracture. So we were discussing in the general orthopedics, right, with respect to what are the types of fracture that is going to present to you. So the intra-articular and extra-articular fracture, this is the same thing. Extracapsular is nothing but outside the article joint, whereas intracapsular is within the article. Okay, so extra articular fracture is not much of an importance, because anyway we'll be doing the conservation, or we are gonna do rods and nails and all these things, because lower limb, right, lower limb is rods and nails. Okay, with respect to internal capsular joint, so management is gonna change. Okay, with respect to age, suppose if the patient is less than 65-year-old, then it is gonna be internal fixation that we are gonna do. Okay, suppose the patient is above 65-year-old, then it is gonna be hemi-arthroplasty that we are gonna do. What we are gonna do is the joint itself is not stable. That is why we are gonna do an implantation with respect to the joint. Okay, so this is the change in management with respect to intracapsular joint, intracapsular fracture of the neck of the femur that we are going to do. There are two types of classification that you are supposed to know. One is Gordon's classification, then other one is Paikin's classification, that you're gonna that is very important with respect to femur fracture. Then the other thing before going into the exam that you all are supposed to know is Austin Moore and Thompson type of implants that we use in the hip joint. Okay, so during arthroplasty or total hip replacement, THR, what we are gonna do is there are two types of implants that they are gonna use. One is Austin Moore and Thompson. They'll ask you to identify what is Thompson and what is Austin Moore. Austin Moore, remember, two words, right? So two words, that is why two holes will be there in the implant. Okay, Thompson, there is no hole, it is going to be plain. Suppose this is the implant that they are asking, so this is how an implant would look like. Suppose if there are two holes here, then it is going to be Austin Moore. Okay, if there is no hole, then it is going to be Thompson. Okay, so Thompson, there is no hole. Okay, that's it. So this is with respect to femur is what you are supposed to know. Now coming down, after finishing femur, it is going to be knee. Okay, in the knee, the main things that are important is the ligaments and meniscus. Okay, so ligaments are anterior cruciate ligament, posterior cruciate ligament, the lateral cruciate ligament, and the medial cruciate ligament. These are the ligaments that are present in the knee. Then there is meniscus, which is medial meniscus and the lateral meniscus. Okay, which is providing a cushion like a structure to the knee. Okay, these ligaments will hold the knee and help in the movement of the knee, whereas these meniscus will provide a cushion like material when the knee joint moves. Okay, so this is on all and everything you need to know. What are the type of knee joints, knee ligaments that are present. Okay, there are two things with respect to these ligaments that you need to remember. One is unhappy triad, where the medial cruciate ligament, the medial meniscus, and the anterior cruciate ligament is involved. Unhappy triad. Okay, so when these three structures are affected, that is called unhappy triad. Okay, so just remember this. Then with respect to the tests, they'll ask you a video based question. Definitely they'll ask you a video based question with respect to tests that that you'll have to worry about. Please go through YouTube, and there are many videos that you can see with respect to latchment test, anterior drawer test, and all these things. I'll tell you what are the test. Just paste these things in your sticky note. This goes to the sticky note. Okay, anterior cruciate ligament, if I want to test, we'll be doing latchment test and anterior drawer test. We'll like what in both these tests, what we are trying to achieve is we'll be drawing the knee anteriorly, so that to check whether the anterior cruciate ligament is there or not, or it is broken. Okay, so this is what we are gonna do. Then with respect to PCL, it is gonna be posterior drawer test. So posterior drawer test, why? Because PCL gives the stability to the knee by not allowing it to go posteriorly, right? So if this is affected, then the posterior drawer test will be positive. Okay, so that is why the PCL. Then with respect to MCL and LCL, we will do valgus and varus test. MCL, what we'll do is, it is gonna not allow the knee to sway to the lateral side, right? So so if it is affected, we are going to put the valgus force and test if whether it is going outside or not. If it goes out, then valgus test is positive, whereas LCL varus test is what we are supposed to do. So this is important with respect to knee ligaments and their tests. In foot, the two important things that you have to remember is Lisfranc and Chopard's fracture, or the amputation levels that are used in foot. Okay, Lisfranc and Chopard. Okay, so Lisfranc is going to be torso-metatarsal joint, whereas Chopard will be intratarsal. Okay, so Lisfranc and Chopard, it is going to be either fractures or it is going to be amputation points that we are going to use. For example, this is the foot, right? So with respect to foot, torso-metatarsal joint, tarsals are these bones, then this is the metatarsal, right? So if the fracture or the amputation I'm going to do in the foot, suppose if it is a diabetic fracture, diabetic ulcer and all, if the surgeon decides to amputate, these are the points that he is going to worry about. Okay, so Lisfranc will be down, and intratarsal, in the tarsals itself if I am doing, then it is going to be Chopard. Okay, L and C, please remember in that way. Then the other thing that they are asking very recently is with respect to the damage to the ligaments of the foot when there is inversion or eversion. Okay, when there is a forceful eversion, that is the foot is going outside, then if the fracture happens, it is going to be the deltoid ligament. This question was asked in 2025 NEETPG paper. Okay, which ligament is being damaged in the forceful eversion. Okay, if the forceful eversion damages a structure, if a forceful inversion damages a structure, it is going to be the anterior talofibular ligament that is most commonly damaged. Okay, if it is going to be forceful eversion, it is going to be deltoid ligament. If it is forceful inversion, it is going to be anterior talofibular ligament. Okay, so this is all and everything you need to know with respect to lower limb. Okay, so lower limb we have covered everything. Okay, so upper limb was done, and the lower limb with respect to the fractures and basic pathologies, we have covered it here. Then moving down further with respect to orthopedics, is bone tumors, infections, and the metabolic disorders and the arthropathies that we will be discussing about. Okay, then the orthopedics is done. So will move on quickly with respect to bone tumors. Bone tumors, I need you guys to remember is ECG, MOSA, and DOSA. Okay, ECG, MOSA, and DOSA. If you remember these three words or the mnemonics, your life is sorted with respect to bone tumors. Okay, so all they are asking with respect to bone tumors is the identification of the x-rays. Okay, so when you see an x-ray and so the main confusions that you are going to get is whether it is a bone cyst that is there or a giant cell tumor that is there, because all of this look the same. Okay, so just by knowing these mnemonics, you will be able to identify whether it is epiphysis or metaphysis or the diaphysis that they are talking about. If you see an x-ray, if it is metaphysis, this is the diagnosis. If it is epiphysis, this is the diagnosis. So that is how we will rule out the differential diagnosis. So suppose the x-ray looks the same. So ECG meaning E stands for epiphysis. Here in MOSA, M stands for metaphysis. Here in DOSA, it is in D stands for diaphysis. Okay, so if there is a epiphyseal tumor, then ECG. CG stands for chondroblastoma and GCT, that is giant cell tumor. So this is just gonna look like a soap bubble appearance, right? So it is gonna be in the epiphysis. Suppose this is the bone, a long bone that we are talking about. If it is in the epiphysis and the soap bubble appearance you will see in the epiphysis, then it is gonna be GCT. Okay, coming down to metaphysis, it is gonna be osteosarcoma. I'll tell you how it is gonna present to you. Then it is gonna be simple or aneurysmal bone cyst. See, GCT also looks the same. Simple bone cyst and aneurysmal bone cyst also looks the same. But if it is in the epiphysis, it is gonna be GCT. Whereas in the metaphysis, it is gonna be simple cyst or aneurysmal bone cyst. See, both of them looks the same only. So soap bubble appearance. Okay, one more thing is aneurysmal bone cyst will be one single whole thing will be a cyst. Okay, so this is how it's gonna present. Okay, so that is how you can differentiate a x-ray. Then with respect to osteosarcoma, there are two main things that you need to be aware of: Codman's triangle and the sunburst appearance. Okay, so this is the Codman's triangle. In the metaphysis, it is gonna present with, see, this looks like a triangle, right? So this is how it is gonna look like with respect to osteosarcoma. Then the sunburst. So if there is a sunburst of appearance, it looks like a sun and a burst, sun is bursting out, then it is going to be osteosarcoma in metaphysis. Then coming to diaphysis, it is going to be osteoid osteoma, Ewing sarcoma, and adamantioma. Ewing sarcoma, this you would have studied hundreds of times, that is onion peel appearance. This is how a onion peel appearance would look like, right? So this will be in your diaphysis. So that is how you differentiate an x-ray with respect to bone tumors: ECG, MOSA, and DOSA. If you remember this, your life is sorted with respect to bone tumors. Then moving down without wasting any other time, so let us move on to infections. There are two types of infections that you need to worry about. One is osteomyelitis, then another one is TB. Osteomyelitis you would have studied in your final year, right? Osteomyelitis has always been there. This is one pakka question, either it might be in the theory exam of orthopedics or the practical exam of our orthopedics. Okay, osteomyelitis will be caused by many organisms, but two main organisms that you need to be aware of is Staph aureus is the most common organism. If a patient presents to you with sickle cell anemia, or he tells that I have sickle cell anemia and presents with osteomyelitis, then it is going to be Salmonella typhi, the typhoid causing bacteria, which will be causing this. This should go to your sticky note. Okay, so Staph aureus is the most common organism that causes the osteomyelitis, whereas in sickle cell anemia patients, it is going to be Salmonella typhi that is going to cause the osteomyelitis. Okay, there are two types of osteomyelitis. One is acute and the chronic presentation. Acute presentation, there is gonna be the prodromal symptoms of pain, temperature rise will be there, tenderness will be there, all this redness will be there, all these things will be there. And what you are supposed to do when there is an infection, you do surgical drainage and will give antibiotics. That is the only thing you should be aware of with respect to acute management. Cloxacillin, because staph aureus. When we go to microbiology, I'll tell you why cloxacillin we are using with respect to staph aureus. So wherever you see a name called staph aureus, you just think of cloxacillin. Okay, so this is the best advice I can give you. Whenever you see the word staph aureus, just think about cloxacillin. Even in your clinical practice, this is the thing that you need to be aware of. Okay, acute is done. Then with respect to chronic presentation of the osteomyelitis, it is going to be sequestrum, cloaca and involucrum. Okay, you know that, right? Sequestrum, the dead bone; cloaca, the sinus that it forms; then involucrum is the new bone formation that we can see in the bone. Okay, how we are going to manage? We are going to use PMMA beads. Okay, PMMA beads can be used, or if it is not healing, then we can go for muscle or bone graft that we can use. Okay, with respect to chronic osteomyelitis. Now moving on further, osteomyelitis is done. Now we will go on to TB. Okay, so TB is the most common infection that we'll see in the part of India. Okay, so Indian regions we'll see the TB. TB is gold for all the medical practitioners in India. Okay, so the thing that it causes is it causes many different infections in our body. So when it comes to bone, also it is going to be very important, because there is TB spine, TB hip, and TB knee that we are supposed to be worrying about. Okay, so with respect to TB spine, it is going to be the paradiscal area that it affects. Okay, this was a previous year question that was asked. Okay, what area of the disc that does it affect? Paradiscal. So suppose this is a disc. Okay, so this is the center and this is the paradiscal area. Okay, this is the paradiscal area. Okay, this is what the TB spine gets affected. Okay, this is the area that the TB spine gets affected. How is the patient gonna present with? He's gonna present with paraplegia. See, the TB spine is affecting the paradiscal area. Here the nerves are passing. Okay, so lower limb nerves are passing. If the lower limb nerves are getting affected due to the infection, or there is erosion of this bone, then it is going to be paraplegia, paralysis of the lower limb. Okay, so paraplegia is what the patient's gonna present with. How are we supposed to manage it? So the main thing is investigation, that is biopsy of the discal area, paradiscal area. Okay, so the biopsy of paradiscal area is the main investigation of choice with respect to spine. These all the things that I told you were asked in the previous year exams. Okay, either it may be INACT, NEETPG, many things. This is the question that what they were asking about. Then with respect to TB hip, there will be the presentation of the patient will be shortening of the limb, is how they'll present to you with. Management is girdle stone arthroplasty. What we'll do is we'll cut off, the main thing is, if this is the femur head and this is the acetabulum, the main thing this TB will present with is the infection of this entire area. So what we'll do is cut off this entire area, that is known as girdle stone arthroplasty. Okay, so TB hip is this. TB spine, you got to know paradiscal area, paraplegia, whereas TB hip, shortening of the limb, because this entire zone is affected, so that is why we'll remove the entire zone. With respect to TB knee, it is going to be triple deformity the patient is going to present with. One is posterior subluxation of the knee, external rotation, and the flexion of the knee. Okay, so this is how a patient will present to you when he'll be having the TB knee. Okay, just there is a beautiful image in Google. Just go through that image with respect to how the patient will present with. Okay, so this is with respect to TB knee. Then, now that we are done with our bone tumors and infections, it is very important that we learn about the metabolic disorders of the bone. Okay. So, with respect to metabolic disorders, there are three main things that you should be aware of. One is there is the metabolic disorder based on minerals, based on the matrix, then based on the cells. Okay, so these are the main things, and it will be very easy if you go through this manner to diagnose a disease of bone or the metabolic disorder of a bone. Okay, how is the metabolic disorder of a bone will present to you with? They'll present to you with inability to walk or inability to do certain functions or certain like increase in hat size, all these things, and weakness, and all these things is how the patient is gonna present to you with. So when the patient comes to you with those symptoms, how are you gonna like differentially diagnose it and come to a conclusion? So that is how we'll see. Okay, so the minerals that we are supposed to remember with respect to metabolic bone disorders is PTH and vitamin D. Okay, so parathyroid hormone, all these things, what is the function of parathyroid hormone and all these things, I'll be discussing in endocrinology. But for now, just remember, parathyroid hormone is the hormone that wants to keep the calcium in the blood. Okay, parathyroid hormone wants to keep the calcium in the blood. Calcitonin is the hormone that makes the calcium level decrease in the blood. Okay, these two are antagonists with each other. Okay, PTH and calcitonin. Okay, so remember in that way. So calcitonin doesn't want the calcium to stay in the blood, whereas PTH wants the calcium to stay in the blood. So PTH, what does it do? So it wants, so when the PTH is released, it goes and acts on the calcium sites. Okay, what is the calcium site in our body? It is the bones, right? So what it does is goes to the bones and causes resorption or the breakdown of the bones and makes the uh, calcium level raise in the blood. Okay, so when this happens, the bones will be resorbed and will have like brittle bones. Okay, so that is when, if we take an x-ray of the skull, it is gonna look like salt and pepper. Okay, salt and pepper. So salt and pepper skull is what it is gonna look like. Okay, if we take a skull x-ray, salt and pepper appearance is because when there is increased function of PTH. Then coming to vitamin D, what it does is it is gonna make the bone. Okay, so vitamin D's function is making the bone, whereas PTH function is breaking the bone, because it wants to keep the calcium level. It doesn't want to affect it. It's not like its function is not to affect the bone. It just wants calcium to stay in the blood. So where is the calcium is in the bones, right? So that is how it acts on. Vitamin D makes the bone. So when vitamin D is not available, then the uh, pathology that we will see is rickets in kids and osteomalacia in adults. Okay, so when the vitamin D is not there, when there is deficiency of vitamin D, we are gonna see rickets in kids, whereas osteomalacia in adults. So these two are same things, same presentation that they are gonna come with, but in kids, if they come with, then it is gonna be rickets, whereas in adults they will be coming with osteomalacia. How the osteomalacia and the rickets patient will present to you with? If suppose in the question they'll tell you a bored leg, a patient presenting you with bored leg, then it is going to be vitamin D deficiency. Think it in that way. Bored leg, if it is a kid, it is going to be rickets. Bored leg, if it is an adult, it is going to be osteomalacia. That is all and everything you need to know. Then moving on with respect to the pathologies based on matrix or the collagen of the bone, it is going to be vitamin C and the congenital disorder that is called osteogenesis imperfecta that we are supposed to worry about. Vitamin C, when we are discussing in biochemistry, I'll tell you about. So vitamin C is not there, then it is going to cause scurvy where the collagen material is damaged or collagen material formation is affected. Okay, so this is with respect to vitamin C. Collagen is very important in formation of bones and tendons, ligaments, all these things. Okay, if the collagen is not there, we'll discuss more about this in biochemistry, but for now remember, when the vitamin C is affected, the collagen is affected, so the bone will also be affected. Okay, that's it. Then coming to osteogenesis imperfecta, the two genes, that is Coca-Cola. Remember in that way, osteogenesis imperfecta is cola. How is the patient gonna present with is, suppose this is a long bone, then there will be intermittent breaks in the long bone. This is how the osteogenesis imperfecta patients will be presenting with. Okay. Now coming to the cells, the metabolic disorders based on the cells. Okay, so we have three things I told you, right? Minerals, matrix, and the cells. Minerals we discussed, PTH and vitamin D. Matrix, that was see, matrix is nothing but if bone is there, the cells are there, osteocytes. This extra cellular structure is called matrix. Okay, these matrix structure is formed by the procollagens. If the procollagen is affected, then it is going to present with scurvy or osteogenesis imperfecta. So this is how you should be able to differentially diagnose it. Now going on further with cells. Okay, so cells, there are two types of cells I told you, right? One is the maker, one is the breaker. Okay, the builder is osteoblast, right? So with respect to osteoblast, if there is increased function, see, so osteoblast is a builder, but if the building is there is too much function of the building, so what happens is there is a pathology called Paget's disease. Okay, so where increased thickness of the bone and all these things will happen. So that is when cotton wool skull will happen. Okay, so Paget's disease is gonna present with cotton wool skull. So where you can see increased head size, hat size. So suppose I was buying a hat for certain size. If the hat size has increased suddenly, then it is gonna be Paget's disease. Okay, because the bones building has been increased. Okay, building power has increased. So if the osteoplastic function has increased, then it is going to be the Paget's disease. Coming to osteoclast, if it has increased function of osteoclast, that is osteoclast is the cutter, right? So cutting, if the cutting is too much, then it is going to be so osteoclastic activity. So what happens is, if there is increased function, then it is going to be osteoporosis, because cutting function is more, and the resorption of the bone has been increased. Why does this happen? Because this happens mainly when there is decreased estrogen function. One of the major function of estrogen is to stabilize the bone. Okay, or decrease the osteoclastic activity. That is why in postmenopausal women, the estrogen will be decreased, right? So when the estrogen is decreased, that is when the osteoporosis will happen. Osteoporosis is most common in females beyond 50 years. Okay, so that is how you'll have to remember. Suppose if there is decreased function of osteoclast, so cutting function is not there, so there is increased function of osteoblast. So that is how we saw the Paget's disease also, right? So but here the osteoblastic activity is not increased, rather the osteoclastic activity is decreased. So that is when we'll see a pathology called osteoporosis, I mean osteopetrosis. Okay, when there is decreased osteoclastic activity, then it is going to present with osteoporosis. How are we going to manage osteoporosis is bisphosphonates. Okay, so bisphosphonates, what it does is it just like estrogen, it is gonna go and act on osteoclast and decrease the osteoclastic function. Okay, so that will help with respect to bisphosphonates. There is an important complication or a side effect of the bisphosphonate when we use it more than 3 years. Okay, please remember this is more than 3 years, not 1 year or 2 years. Okay, more than 3 years if we start using, then there is a complication or a side effect of this bisphosphonates when there is a long-term use, that is going to be the fractures of the long bone and also osteonecrosis of the jaw. Okay, so remember this, please remember this. Okay, that's it. Then, with respect to the congenital or a genetic disorder, there is something called achondroplasia. Okay, achondroplasia, where the cartilages of the body is affected. This affects mainly in from the birth itself, right? So cartilage is what forms the bone. So when this cartilage formation is affected, it is going to present with achondroplasia. The main gene that is involved in achondroplasia is FGFR3 gene. Okay, FGFR3 gene, please remember this. Okay, how is the patient gonna present with? He'll be dwarf and starfish finger. This is very pathognomic with respect to achondroplasia. Please remember this. If a patient is dwarf, you have if you have seen Game of Thrones, Peter Dinklage, right? So he'll be Tyrion. Okay, so if you know him, remember him, and he's having achondroplasia. It will be dwarf, and if you would have seen his fingers, he has starfish fingers. Okay, his fingers would look something like this, like a starfish. Okay, so that is how the presentation of achondroplasia looks like. Okay, now further we are done with metabolic disorders also, so we'll be moving on with arthropathies. So with respect to arthropathies, it is gonna be the joint pathologies that we are discussing about. Okay, so in joint pathologies, so we are focusing on osteoarthritis, rheumatoid arthritis, gout and pseudo gout. Then it is going to be non-rheumatoid arthropathies, that is psoriatic arthritis, ankylosing spondylitis, and then it is going to be reactive arthritis. Then there is the infection of the joints, that is septic arthritis and TB arthritis we'll be discussing. Okay, so few points about all these pathologies with respect to joints we'll discuss, and these are the only things that you need to be worrying about with respect to joint pathologies. Okay, starting with, there is the difference between osteoarthritis and rheumatoid arthritis. Okay, because they'll ask you to differentiate between, the questions will be clinical, but you should identify osteoarthritis or rheumatoid arthritis that we are talking about. Okay, osteoarthritis, the main thing how it happens is because of wear and tear of the joint, whereas rheumatoid arthritis is mainly autoimmune. In autoimmune, the main HLA that is affected here is HLA, or the main associated HLA is DR4. Remember R. Okay, so when R is there, it is gonna be rheumatoid arthritis. Okay, so DR4. What is this autoimmune disease, HLA, all these things I'll be discussing about this in pathology, general pathology. Okay, for now you remember there is osteoarthritis and rheumatoid arthritis. Osteoarthritis because of wear and tear as aging occurs, or when if there is increased usage of the joint, then it is going to be osteoarthritis, whereas rheumatoid arthritis is mainly autoimmune, where our own cells are destroying the joint. Okay, then here the main clinical feature it is gonna present with is, in osteoarthritis the pain improves with rest, whereas rheumatoid arthritis pain improves on use, on as the day goes on, as you start using it more, the pain is not there. Okay, with respect to rheumatoid arthritis. Then in osteoarthritis, as it is because of wear and tear of that particular joint, it is going to be having no systemic symptoms, whereas rheumatoid arthritis, as it is an autoimmune disease, it is going to have some extra articular features. The main two extra articular features that you need to be aware of is interstitial lung disease and pleuritis. Please remember pleuritis with respect to rheumatoid arthritis. Okay, then the pattern more common will be lower limb then upper limb with respect to osteoarthritis, whereas rheumatoid arthritis, it is going to be upper limb more than lower limb. If you guys would have seen any of the clinical cases in your internship, then it is you would have definitely come across rheumatoid arthritis in some or other one, whether it is in general medicine or in orthopedics. It is going to, you would have seen definitely it is going to be upper limb that will be affected in most of the people rather than in lower limb with respect to rheumatoid arthritis. Then one more main thing that you can be aware of with respect to osteoarthritis, when it comes to which joint it is involving, it is going to be DIP, that is distal interphalangeal joint, more than proximal interphalangeal joint. Whereas when it comes to rheumatoid arthritis, it is going to be MCP more than PIP. Okay, so they'll give you an X-ray and they won't tell you about any features, anything. Then they'll tell you whether it is osteoarthritis or rheumatoid arthritis. Then some other options they'll give you. So you should be able to diagnose this just based on the X-ray that they have provided you. Suppose if the X-ray has a damage here in the distal interphalangeal joints, then it is going to be osteoarthritis. If suppose the damage we see is in metacarpophalangeal joints, then it is definitely rheumatoid arthritis. Okay, this is how we differentiate it based on the X-rays. Okay, so the other main clinical feature is swan neck deformity, which will be in the rheumatoid arthritis. Okay, swan neck deformity, it looks just like a swan. Okay, so swan neck. Okay, so this is how a swan would look like, and this is how a swan neck deformity would look like with respect to rheumatoid arthritis. Okay, then with respect to the joints features. Okay, so suppose if they are asking a joint feature, they are describing a joint feature, and you should be able to diagnose or differentiate between these two. So divide it as capsule, synovial fluid, cartilage and bone. Okay, in a joint, suppose there is a joint, this is a bone, this is also a bone. There are structures that are important with respect to bone. One is capsule, which surrounds the joint. There is synovial fluid within the joint. Then there is a cartilage that is in the joint. We discussed, right, many of the cartilages with respect to knee joint and all. Then there is bones. Okay, the major thing is bone. So these are the features that the joint, these are the structures the joint will be having. So they'll ask you to differentiate the osteoarthritis or rheumatoid arthritis based on these joint features. Suppose if the capsule is thickened, then it is gonna be rheumatoid arthritis, osteoarthritis. If there is pannus, hypervascularity and increase in capsular size, then it is gonna be rheumatoid arthritis. When it comes to synovial fluid won't be affected in osteoarthritis, whereas in rheumatoid arthritis, synovial fluid will be increased in amount. Okay, then when it comes to cartilages, the cartilage, because it is wear and tear, the pathogenesis of osteoarthritis is wear and tear, right? So cartilage will be thinned, whereas in rheumatoid arthritis it will be eroded because of the autoimmune disorder. Okay, when it comes to bones, we will be seeing osteophytes and subchondral sclerosis in osteoarthritis, whereas in rheumatoid arthritis it will be eroded. Okay, cartilages are also eroded, whereas bones are also eroded with respect to rheumatoid arthritis. This is how you would differentiate osteoarthritis and rheumatoid arthritis when given a clinical question. Okay, just go through this once again and you will be sorted. Then there is something called gout. Okay, so where there is increased amount of uric acid or certain crystals that will be in the joints. Okay, so we were discussing about the joints and joint fluids, right? So suppose if there is increased amount of certain crystals, I'll tell you what crystals. So suppose there is increased amount of crystals in this synovial joint, then it is gonna form two pathologies called gout and pseudo gout. Okay, if the crystal is a monosodium urate or uric acid based crystal, then it is gout. If the crystal is calcium pyrophosphate, then it is gonna be pseudo gout. Gout has needle shaped crystals, whereas pseudo gout has rhomboid shaped crystals. Gout has negative bisfringence, whereas pseudo gout has positive bisfringence. Just by looking at the bisfringence, you will be able to diagnose. They'll definitely give you bisfringence with respect to gout or pseudo gout differentiation. So based on this thing itself, you can diagnose what the pathology is. Then in both of this, the presentation, if it is acute, will be pain and inflammation, because it is a joint, right? So pain and inflammation. If it is chronic, then there is tophus formation and there is degeneration of the joint. How will you manage both of these gouts? Same management. Only with respect to diagnosis it is going to change, but management and how it is going to present, it is going to be same for both of this. Okay, suppose if it is acute, then we are going to go with colchicine. Remember, this is an important point. Uric acid itself is an anti-inflammatory. Okay, uric acid is itself is an anti-inflammatory. Inflammation is what is the presentation of this gout, right? So suppose if I start reducing the uric acid in the joint, then the anti-inflammatory activity of the uric acid itself will be removed, right? So that is why we'll go for colchicine first, then for allopurinol. Okay, so colchicine, I'll tell you the mechanism of colchicine and all later, but for now, remember ACCA. For acute, we'll go for colchicine, whereas for chronic, we'll go for allopurinol. Other than that, we can give NSAIDs as the treatment for this gout. Okay, remember it as AC and CA. Okay, for acute colchicine, whereas for chronic, it is going to be allopurinol. Then there are other drugs also like febugostat and all these things. That is not much of an important here. So just remember, for acute colchicine and chronic allopurinol. Then the last thing, that is the non-rheumatoid arthritis. Okay, so what we discussed above was rheumatoid arthritis was autoimmune, whereas this is non-rheumatoid factor arthritis, where HLA B27, there it was DR4. That is why I told you to remember the R. R is with respect to rheumatoid arthritis, whereas B27 is with respect to this non-rheumatoid arthritis. There are different types of non-rheumatoid arthritis. Main thing is psoriatic arthritis, where the association with psoriasis we will be discussing in dermatology. So if psoriasis is there and there is arthritis, then it is going to be psoriatic arthritis. If we see an X-ray, there will be pencil cup deformity, which is just like this. Okay, so pencil cup, this is a phalanx. So this is how a pencil cup is gonna present with. Okay, so a normal phalanx would look like this, whereas the pencil cup deformity would look like this. Okay, so pencil cup deformity in psoriatic arthritis. Ankylosing spondylitis, the only thing that I want you guys to remember is the first joint that will be affected is sacroiliac joint. So that is why when we take an MRI, the best method to diagnose this is MRI, not X-ray. Please remember this. This is X-ray is not the thing that we use for diagnosis. It is going to be MRI, and we are going to take the sacroiliac joint MRI. The main thing that will be affected here is spine. Okay, Then the x-ray, if we take, it is going to be bamboo spine. A bamboo spine x-ray they'll give you, and they'll tell you what is the best choice of investigation. So it is going to be MRI, that is going to be the best choice. Okay. Then coming to IPD, it is going to be spondyloarthritis, the inflammation of spine joints. Okay, so spondyloarthritis is one of the non-rheumatoid arthritis. Then reactive arthritis is Reiter syndrome. Remember, can't see, can't pee, can't move my knee. These many three types of can'ts we'll be seeing. For example, in Alport syndrome, it will be can't see, can't pee, can't hear a bee. Okay, so many of these things I'll tell you at the end of the session. I'll tell you about the these can'ts. Okay, there are many other can'ts, like I told you, right? This is Reiter syndrome, can't see, can't pee, can't move my knee. Whereas in Alport syndrome, it is going to be can't see, can't pee, can't hear a bee. Okay, so in that way. Then, now that we are done with non-rheumatoid arthritis, we'll move on to septic arthritis. Septic arthritis, it is going to be most common organism, just like osteomyelitis, is Staphylococcus aureus, and if it is sexually transmitted infection, then it is going to be gonococcus. Okay, if a person presents to you with STI and he's telling he's having a joint inflammation and a pain, then definitely it is going to be gonococcus. Staph, how are you going to treat? If it is going to be Staph aureus, I told you, right? Cloxacillin. Wherever you see the word Staphylococcus aureus, it is going to be cloxacillin. Why is cloxacillin? I'll tell you later in microbiology. When it comes to TB arthritis, it is going to be Femstus triad that you should be aware of. Okay. Then one more thing I wanted to remember is, in septic arthritis, if a purulent discharge is seen, then it is going to be purulent arthritis. Okay, so these are the things that you need to remember with respect to infection of the joints. Okay, so that is all and everything about orthopedics. This is very important. This is all and everything you need to know. Just in 1 hour I've taught you, 1.5 hour. So please remember all these points, and just there are only 2 pages of this. All 1.5 hour is just in 2 pages. If you give 5 minutes and just revise this, you're done with orthopedics. Okay, and just do certain questions, just 20 questions or something in custom module in any of the app, and you will be done for orthopedics. Thank you.